customers, insurers, and mental health professionals, and balancing those interests. For the folks who are interested parties joining us today, we will have a public comment period at the end. So we do receive feedback from all who are interested in this topic. And I'm getting a bit of feedback, so just a reminder to mute yourself if you are not speaking. All right. So moving through, we're going to do some introductions, which will take some time. This is our first meeting, so I felt like it would be good to kind of go through the whole kind of introduction business, which can be kind of clunky on this virtual format. What I will do is I will start with the Rulemaking Advisory Committee members to introduce themselves, and then we'll move on to the interested stakeholders, and then finally with any DFR staff who are on the phone or in the meeting. Before we get started with the RAC members, I see that Rep. Nose, you are here. I don't know if you want to introduce yourself and say a few words before we launch into the meeting. And if you're speaking, you are on mute. All right, we'll come back to you, Rep. Nose, and we'll kind of start the introductions going through. First on my list is Antoinette from Cambia, or the representative you have from Cambia to introduce themselves.
Hi, yes, this is Antoinette, and I'm the Senior Regulatory Affairs Specialist for Cambia Health, and I will be attending this with Vince Porter, my director. He's not online right now, but he will be joining us in a few minutes. Thanks for having us.
Thank you. Next up is Dr. Garner from the Oregon Psychiatric Physicians Association.
Yes, good morning, everybody. My name is Bennet Garner. I'm a child, adolescent, and adult psychiatrist representing the OPPA. And I apologize, but was unable to resolve a conflict, so I'll have to jump off around 11 o'clock.
Thanks for being here. And Rep. Nose, I see that the technology has worked and you are here. So if you want to introduce yourself and say some initial thoughts.
Sorry about that. I was in the meeting and I got kicked out. So, but I'm back. Hello, everyone. And to the advisory committee members and interested parties, I'll just say thank you for both your interest and for being willing to help shepherd the next phase of this legislation into reality. And Cassie, normally it will be Seth Dugan Knight from my office who will be monitoring this, but he's on vacation today. And so I thought I would join in his stead just in case there was anything he would need to know or miss. So thanks for having me, and I look forward to this getting going.
Great. We're happy to have you here, and we'll be happy to have Seth here when he's back from his vacation, fully rested, hopefully. Next up is Cheryl Ramirez. I don't know if she was able to jump on. She said she was going to be a little bit late today. All right, we'll move on to Chris from NAMI.
Hi, Chris Bonaf with NAMI, Oregon.
Fabulous. Next up is Dan from MODA.
Good morning, Dan Toma. I'm the Senior Manager of Behavioral Health for MODA Health, and was involved in negotiations creating this bill, as well as House Bill 3090 and 3091.
Gary from Pacific Source.
Good morning, Cassie. Gary Holiday, Commercial Compliance Manager for Pacific Source. I will be joined by Michelle Beard and Rick Blackwell during these meetings, and I appreciate the opportunity. Thank you.
Next up is Jim Davis. All right, moving on, Jen Baker.
Good morning. Sorry, Jennifer Baker, Director of Government Affairs for Providence Health Plan, and I am joined by Randy Adair from our health plan as well.
Great. Next up is Laura Curtis.
Good morning. My name is Laura Curtis. I use she, her pronouns. I am the lobbyist for Basic Rights Oregon.
Wonderful. Melissa Todd.
Hi, I'm Melissa Todd. I'm here for the Oregon Independent Mental Health Professionals. I am a psychologist in private practice in Eugene.
Next up is Rachel Wiggins Emery.
Hi, everyone. Rachel Wiggins Emery. I'm the lobbyist on behalf of COPACT, who represents the professional counselors and marriage and family therapists in Oregon. I sort of led the work on the bill on behalf of the behavioral health providers and consumer advocates, so I'm really excited to be here with you all.
And last on our list is Tim Clement.
Hey guys, thanks for having me and being part of this process. Tim Clement from American Psychiatric Association. I worked on the legislative process on this bill, and also I work with many state insurance departments on parity implementation. So good to be here.
Great. So that wraps up the majority of our rulemaking advisory committee members. Was there anyone who is on that list that did not get to introduce themselves? All right, we'll move on to the interested stakeholder portion. If you want to briefly introduce yourself, this will be kind of clunky, but roughly in alphabetical order by last name. Let's kind of hear who's on the line.
Elise Brown, America's Health Insurance Plan.
Hi, Sadie Elwood with Kaiser.
Katie King with OPPA.
Dave Neslikas, Moda Health.
J.L. Wilson with the Oregon Independent Mental Health Professionals.
This is Belle Shepherd with OHA Government Relations.
Samantha Byers with OHA Health Systems Division, Behavioral Health Division.
Nathan Roberts, Oregon Health Authority Health Systems Division with Medicaid programs.
Tristan Fernandez, OHA Government Relations.
This is Jim Davis. I am the chair of the Oregon Disability Commission and also chair of the Oregon Older Adult Disability Behavioral Health Advisory Council and a lot of other senior and disability advocacy groups and coalitions as well.
All right, anyone else want to introduce themselves before we move on to DFR staff? Okay, we'll move on to the Division of Financial Regulation staff who are on the phone. I realized I didn't introduce myself when I kicked the meeting off. So you all know, my name is Cassie Susi. I am one of the senior policy advisors at the Division of Financial Regulation. I've worked with several of you on other health insurance issues or other insurance issues because I kind of do a lot of different subject matter across the division. But some of you, this is the first time we're working together, and I'm looking forward to the rulemaking process and kicking things off. And if you're wondering, one of our colleagues, Gail Woods, usually leads this work, and she is out on medical leave. So myself and my colleague Lisa are stepping in to kind of get this work started, since we know that there's a lot to do and there's timelines are fast approaching, at least for reporting guidelines and other fun things that are in the bill. So we wanted to kick things off and get them started. So I'll pass it over to Lisa to introduce herself.
Good morning. Welcome, everyone. I'm Lisa Emerson. I am a Senior Health Insurance Programs Analyst for Division of Financial Regulation. Welcome.
All right, I think Karen is also on the line. She's a good person for you all to know because she's our rules coordinator, knower of all things rulemaking, and can help get you to the right spot or get you the right information if you need to get in touch with someone from our division.
Hi, I'm Karenwinkle, and I am, as Cassie said, the rules coordinator for the division. And I'm kind of the one that is monitoring timelines as I am coordinating and herding all of the rulemaking for this season.
She keeps us all on track and making sure that we don't miss anything. So anyone else from the division want to introduce themselves?
Hi, this is Rick Berry. I'm the Health Forms Lead, and I'm joining today on behalf of Tasha Sizemore, Product Regulation Manager.
This is Spencer Peacock. I'm the Lead Data Analyst for the Division of Financial Regulation.
Wonderful. All right, so we'll get started in kind of going through. You all have the agenda before we launch into it, which we're like right on time. So great work with introductions, because I know that can sometimes eat up a lot of time. Before we begin, I just want to briefly outline some ground rules to help our meetings run efficiently in this virtual environment. Like I said at the beginning, please make sure to keep your audio muted to reduce the background noise or fun kind of repetitive noise tunnels that happen while we're on these virtual meetings. For video, RAC members are invited to use the video for the meeting discussion if that is your preference. It's not required. We ask that all other meeting participants keep their video off just for the purposes of the recording and whatnot. RAC members are encouraged to utilize the raise your hand function to help kind of facilitate the conversation. Not required also, but it just helps. If you are an interested party and would like to provide public comment at the end of this meeting, please send a chat to Karenwinkle, or you can put your name in the general chat for the Rulemaking Advisory Committee, and we will get to that and call on you when we get to the public comment portion. If you're on the phone, when we get to the public comment portion, just unmute and let us know that you would like to provide public comment. We also encourage not only the interested parties, but also the RAC members to submit any written feedback or comments to the division to help this process. Like I said, this meeting is being recorded. We will post the recording and all of the RAC materials to the DFR website. That should be up and running in the next week or so. As with many people, we have quite a few folks who are on vacation, so we will get the website up and running so that we post all of the materials there. All right, so moving on, we'll do kind of a brief overview of the mental health laws, which some of you are probably very familiar with and have worked on throughout the years, but want to provide that background material for everyone as a foundation before we start digging into deeper conversations. So I'll pass it over to Lisa to provide an overview of the Mental Health, Parity, and Addiction Equity Act, the federal law.
Thanks, Cassie. So yeah, just a brief intro and refresher for some of you. So the Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act of 2008 is a federal law that generally prevents group health plans and health insurance issuers that provide mental health or substance abuse or substance use disorder benefits from imposing less favorable benefit limitations on those benefits than on medical surgical benefits. The Affordable Care Act of 2010 amended this act to also apply to individual health insurance coverage. Cassie?
Yeah. So next up, we'll talk about the bills in Oregon. The first laws were adopted actually in 1975, and it's undergone several changes since then. Most importantly, one of the biggest bills that amended the mental health parity law was in 2005 with Senate Bill 1, when the requirements for the existing mandate were extended to parity coverage for chemical dependency, and that's the language that is used from that law and is also in our rules for implementing that law. Those have been changed by House Bill 3046 so that it will be part of our rulemaking process, is updating some of that language and the terminology that is used. In 2017, as mentioned by some of our RAC members, House Bill 3091 further clarified the scope of services to be covered for people experiencing a behavioral health crisis in an emergency setting, and it defined the type of provider authorized to conduct a behavioral health assessment. In 2019, the law was modified again to clarify the requirements applicable to individual and group health benefit plans. Another law that was passed was Senate Bill 860, which required our department to conduct an examination of insurers in 4 areas. The first being historical trends for the insurer's maximum allowable reimbursement rates. It also looked at utilization management procedures, whether insurers pay equivalent reimbursement for time-based codes, and some other kind of data points, and whether the methodologies that were being used were equivalent to for out-of-network reimbursement. I think the methodologies being used were equivalent to in-network behavioral health providers and between in-network behavioral health and then medical providers. We did include a link to the Senate Bill 860 report in the agenda. If you did not get that for some reason and would like to take a look, we're happy to send you that. That is also on the DFR website. It's pretty extensive and covers a lot of information. It also includes some recommendations as well that are related to mental health parity. And the bill that we are all here for is House Bill 3046, which I assume most of you are very familiar with. So I'll do a kind of quick rundown of the main sections that are applicable to DCBS. The bill kind of has like 2 separate tracks, one that involves DCBS and individual and group health plans, and then there's some information that is applicable to CCOs. So that would be more on the OHA side of things. But starting with section 2, and this will hopefully be some of our conversation today and our kind of next RAC meeting, is about the annual report from insurers on behavioral health benefits. And so this report is required to be submitted to DCBS by carriers and includes information on non-quantitative treatment limits, the factors that are used to determine those NQTLs that are applicable to mental health, substance use disorders, medical and surgical benefits. What the evidentiary standards are used to use those factors and determine to use those factors. A comparative analysis demonstrating the use is not more stringent than the NQTLs used for medical and surgical. Findings and conclusions from the insurer on compliance with the standards above, and then also with federal standards. And then there's a bunch of quantitative kind of information on number of denials, percent of denials appealed, and the percentage of appeals upheld or overturned. The percent of claims paid to in-network and the percent paid to out-of-network providers, the medium maximum allowable reimbursement rate for a time-based office visit, reimbursement rates in different geographic regions for the several different types of behavioral health providers. Like I said, compliance with the state and federal mental health parity laws, and then kind of an open-ended other data and information deemed necessary for us to understand compliance with mental health parity. That is section 2. The report is due in March of 2022. So that is coming up. I know it's August, but it feels like March is very quickly around the corner. Moving into section 5, and this is really deals with the treatment of behavioral health conditions, specifically in ORS 743A.168. That is the section that is amended by section 5. So there's a lot of updating of definitions and terminology that we will need to go through the rule that is applicable to this and also update that language. It adds language to include co-payments in the comparative analysis with hospitalizations, so comparing a mental health claim to hospitalizations. It requires coverage of behavioral health treatment to include treating of the underlying patient condition rather than amelioration of symptoms, treating co-occurring behavioral health conditions or medical conditions in a coordinated manner, treatment that is least intensive or restrictive must meet the needs of the insured's condition and is comparably safe and effective as treatment at a higher level of service. Treatment must be allowed to maintain functioning and prevent deterioration, and treatment for the appropriate duration based on the insured's particular needs, or if there are unique needs to a child, adolescent, or older adult. Additionally, this section specifies that coverage may not be limited, coverage may not limit like the coverage of a chronic behavioral health condition to any short-term or acute treatment if medically necessary to have ongoing treatment, and that the network of behavioral health providers must meet the standards in ORS 743B.505, which is our network adequacy law, and it was also amended by this bill. So we'll talk a little bit about that further down. It specifies that the methodology used, any updates to the methodology for rates, and the reimbursement of out-of-network claims must be in the same or in a manner equivalent to those used for medical and surgical benefits. It also includes an education and training component on the use of medical necessity, utilization, or clinical review to educate insurers, staff, and also participating providers. And then finally, I think I got most of it in section 5, which is pretty extensive. It requires the department to adopt rules for violations if specific billing codes are required to be used or required for reimbursement. So that's going to be a big chunk of our work also. Section 6, really briefly, is network adequacy. Like I said, our network adequacy law, and it includes some additional provisions for behavioral health, for evaluating that annually for behavioral health providers. And includes kind of some data elements there for the department to evaluate each insurer. Section 7 sunsets part of the reporting provisions in section 2, and this is the insurer report. From kind of my look is most of it is these quantitative reporting elements, so the annual report would still be required, but it would remove some of those quantitative, so percentage of denials and things like that after we've had a few years of that. And then Section 8 is criteria and guidelines for behavioral health treatment. These become operative in 2023. So this is kind of, I think, a phase-in approach of what it means to have a generally accepted standard of care for a level of care placement criteria. If that's used, it needs to be developed by a nonprofit professional association, and also can be based on any valid evidence-based sources that are publicly available. So that's some of our upcoming work as well. It is not effective or operative until 2023, so there's a little bit of time for that. And Section 9 outlines those operative dates for the sunset of the reporting provisions, and then also the implementation for the criteria guidelines for behavioral health treatment. Hopefully I got most of the bill, at least related to the DCBS component. But that is going to be the bulk of our work, is developing rules to implement all of that and to make it easy for everyone to achieve compliance with. Any questions about background on Oregon law related to mental health parity, or questions about just the bill in general? All right, we'll move on to, I think, the most engaging portion. You will hopefully stop hearing me talk, and we'll hear kind of more of a robust conversation between our RAC members. We want to kind of walk through the different sections of the bill and discuss the areas where you have questions or recommend clarity. If you already have thoughts about kind of what needs to be included. We will start with Section 2. This is the annual report from insurers on behavioral health benefits. We sent out some questions with the agenda to sort of help guide our discussion here today. And those questions are, is there any other data or information that should be reported on regarding the annual insurer report to help us understand mental health parity? What are any areas that need further clarification, or would it be benefited by further specification in an administrative rule? And are there any other types of considerations for DFR to know about while we're kind of going through this process? So we'll start with Section 2, the annual report, and would love to hear if anyone has any initial thoughts on the annual report from insurers. And Tim, you have your hand raised.
Yeah, thanks. One thing I was just thinking, the Section 2, the language there for non-quantitative treatment limitations is an exact mirror of what is now federal law that passed Congress last year. One thing that I think might be helpful, and this is something I could help facilitate this or even share the document, but I know that the National Association of Insurance Commissioners, they have a parity working group, and they have on their regulator-only website a Word document that is designed specifically to collect this information. Obviously, it's because it's the same thing as what's in federal law, so it's a standardized tool. It's nothing official yet, but it's something that I know that a number of other state insurance departments are using that format. I've been working with a few of them to use that document. I would suggest that it would make a lot of sense maybe to use that because other state regulators are using it. And also it follows very closely. It's really the exact reporting format that's in federal law and of course is mirrored here in statute. And also I think for all parties involved, both insurers and regulators and you as a department, it's a lot easier to do this with a Word document than say some Excel spreadsheet or something like that, because a lot of these analyses are going to be narrative analyses with lots of reporting with words and paragraphs and sentences, things like that. So I would just recommend that if you're interested, that maybe something like that should be considered because it is a tool other state regulators are using right now.
Cassie,
Sorry, I joined late. This is Vince Porter from Regions. Can I just make a comment?
Yes.
I want to just thank Tim for bringing that up and appreciate his desire to have some consistency. I think that's something, since we're in 4 different states and we're dealing with federal guidelines, that as much consistency will make it easier to provide the reporting. And the other thing, as we're going through the rulemaking, if it would be really helpful for all of us to flag where possibly the Oregon law or the rules are going to differ from what federal requirements, so that we can at least identify those and understand that we're doing something different than what we're going to be asked to do in other parts of the country.
Great, thank you both. Appreciate that information, especially, like I said, jumping into this new topic and learning about all the resources that are already out there. I think that is one of our goals, is to make the reporting efficient and consistent as possible, knowing that there's several types of reporting that are out there. So we will definitely take a look at the NAIC Word document, and we can get in contact with our colleagues there to get that. Are there any other thoughts about the annual report?
Just one other thing I would add, just Cass, the people you'd want to contact, the 2 regulators, the chairs of the committee, are Jane Beyer from the Washington Office of the Insurance Commissioner and Katie Zurich from the Pennsylvania Insurance Department. And the staff at NAIC is Joe Tushner.
Perfect. And I've been on calls with Jane on several other health-related topics, and she's a very good resource. Gary.
Hey, thanks, guys. Just a question on this section 2, when we get into the specific data call information you're having, are we going to get into the weeds on that later on? Because we do have some questions there, trying to clarify regions and some of those other things that the bill's brought on.
Yeah, I think we would love to hear what those questions are in terms of the specific kind of data elements. Like I said, we do have some of our data folks. We've got Spencer, he's our lead on kind of all things data for the division. So we do want to hear that feedback as we're kind of thinking through templates and how we implement this. So feel free to kind of launch into your questions.
Well, I mean, I'm not sure if you're going to go through the section 2. Other times the DFR has gone by subsections, and we brought our questions in because our questions kind of fall in that order. So if that's the way you want to go.
Yeah, we can definitely walk through the different subsections for sure.
Because the first 5 steps, or the first 5 issues, the federal law, I have no questions on that.
Got it. Okay. So Dan, did you have kind of a general question, or should we launch into the subsections?
I had a follow up to Tim's comment. I just did a real quick Google search for that NAIC document, and I didn't find it immediately. So I'm just wondering if we can get that sent out to the group.
Sure. I mean, I have, it's sort of it's the NAIC currently, their Parity working group, they have it in a sort of a regulator only portal. But I have the document, and I'm free to share it so I can share it to everyone in this group if you'd like.
That would be great. Thank you.
Sure, absolutely.
All right. So we'll move on to subsection 3, which I think is where most of the reporting components are in section 2. I think the first, several are based on the federal law, which folks are already familiar with. Are there any I think, Gary, you said the first 5 are federal reporting standards already? So
yeah, I have no questions with those.
Okay. Does anyone else have any questions on those ones? All right. So moving on to, I think, the more quantitative stuff, starting with sub E, this is the specific findings and conclusions. Oh, those are just for the federal analysis. Is there any comments or questions on this one? Okay, moving on to the number of denials for behavioral health benefits, medical surgical benefits, the percentage of denials that were appealed, and the percentage of appeals that were upheld, that upheld the denial or overturned the denial. Any comments, questions, concerns about that one?
Into it. The challenge we run into is when we have partial denials of claims. Maybe in the instructions when we develop those for the report, we clarify what is a partial denial, or those included, because we do run into those.
A question that I would have about that is that, is that specifically utilization management denials that we're talking about, or would it be all claim denials?
Generally, it's going to be utilization. Sometimes the providers will ask for, certain types of quantities of prescriptions or certain type of treatments, and we may approve a portion of it at the time and not all of it. And so it's issues we run into when we report these numbers and data. We just like to get real clear for our folks when they pull the data that this is exactly what we want, and that's what I'm trying to do.
Yeah, I was actually asking more generally what the requirement refers to, and if we could have it specified in rule that it's utilization management denials, if that is the intent, rather than any claim that was denied because the member wasn't eligible or for non-utilization management reasons.
Right. No, that'd be good.
What do other RAC members think about defining what a denial means in terms of if it's for utilization management or for other reasons?
Well, I would say I think that makes sense. I don't think we're really interested in knowing about administrative denials and things like that. I think the UM denials would be really what people are looking for.
All right, that is helpful information. I did not know that there were partial denials that happened, so we'll definitely dive into that. Any other?
Just wanted to agree with that as well.
Yeah. Okay. Great.
Yeah, and I'm sorry, can't find the hand thing, but I think the partial denial thing is very interesting, and I'd like to see how it compares to the physical health side. I'm certainly very familiar with the mental health side. So getting some clarification from you all on the insurance side about how that works on the physical health side, so we can compare those things, would be useful for me.
Sure, I can do that. I can dive in a little bit more. Probably at the next meeting right now. I didn't go out and scrutinize that further with my utilization management team. It's one of those things that it just comes up often when we do these data calls, is clarifying partials, but I can get more information on that. That's not a problem.
I guess just one.
Go for it.
I just do have one other thing, and you don't have to have an answer right now. I just popped in my mind. It might be helpful if there's clarification when we're talking about partial denials. Does that include, it's a denial for, say, a particular level of care, but there was then an approval for a lower level of care, if that gets captured in the concept of partial denial? I just thinking that through a little bit. Again, that's just thought at the top of my head. We don't need to have an answer right now. I just think that maybe that's something to think about, is setting the universe of what is a partial denial and what isn't. So I'm not saying that should be a partial denial or a full denial, or I'm just saying that might be one thing that we want to think through when it comes to partial denials, is just make sure we know what that universe is for what is considered a partial denial.
All right. Any other comments or questions about the denials section? All right, so moving on to G, sub G. This is the percentage of claims for behavioral health benefits and medical and surgical benefits that were paid to in-network providers, and the percentage of such claims that were paid to out-of-network providers. Any feedback? All right, seems pretty straightforward. Moving on to H, the maximum allowable reimbursement rate for each time-based office visit billing code for each behavioral treatment provider type and each medical provider type. Any feedback on that one?
Yeah, Cassie, this would help us if we, in this group, we defined, the particular billing code and the provider types. If we leave it to each company, they may come up with a little different version, but it helps if we clarify it in the rules. Either you identify the billing code or the licensed providers that are in play. It generally helps getting everyone consistent data. Do you know if during the legislation any particular billing codes or groupings of provider types were discussed that we can work from?
I mean, this is Rachel.
Oh, okay, go for it.
I can weigh in briefly. I mean, we had a lot of conversation about sort of the, and the code numbers are escaping me, so please forgive me on that. But sort of the difference between the 45 and the 1 hour billing code, which plays a part sort of later in the bill. But I do know that this is a broader discussion than just those two codes. And I would rely on sort of my other coalition members who are participating in this RAC to help identify what specific codes we're looking to have captured in this information.
As far as provider types, I think one possibility would be to use, we've got actually, I guess, two different groupings just following that language in the bill. But then we've also got the groupings that were done in the Senate Bill 860 report, which seems a pretty reasonable grouping, although I think it may be useful to, the way I think about it is for the behavioral health providers, as they were defined in this 860 report, I think of the LCSWs, LPCs, and LMFTs as one group, the master's level clinicians, and then psychologists as another group, and then this nurse practitioners and psychiatrists. I also think of them separately since they often have different reimbursement rates. Sometimes have different reimbursement rates depending on whether they're in independent practice.
Do we want to limit the number of groups, or we want to, I mean, I'm trying to understand what level of detail we want to get at in this analysis that's going to be performed. Is it okay to group, or was there intent that we get to specific provider type? Because what we also notice is some providers will get 2 or 3 licensures, and okay, what bucket do they fall into? And that's why I like the grouping approach. I'm just not sure what is going to provide the most effective analysis. Is 3 groupings, 4 groupings, 5 groupings? I look to RAC to weigh in on that part to help us as health plans.
Those are great points. We are writing all of this down so that we can continue the conversation. Melissa, you have your hand up.
Yeah, and actually, I think Dan already, excuse me, already talked about bringing in SB 860 and the way that we asked that things were looked at, that might be useful in this discussion. But what we're really trying to figure out, kind of going off of what Rachel was saying, is what kinds of trends we're seeing in reimbursement rates between office visits of increasing time. So, you know, on the medical side, it might be 10 minutes, 15 minutes, 20 minutes. On the behavioral health side, it might be 30 minutes, 45, 60. And then this also will help us capture trends in reimbursement over the years. And so from one year to another, or over a span of several years, what trends are we seeing between behavioral health and medical? We tried to get at that in the SB 860 data call, and found that the metric that was used there didn't quite capture what we were looking for. We were looking for more of a picture of aggregated reimbursement rates between behavioral health and medical, rather than the highest possible reimbursement rates that anybody is paid. So we're hoping that this is going to be a more useful metric for that.
Good point. Thank you. Cassie, that brings up the point of when we do in this data, is it just for the prior year? Is that the periods that are going to be submitted under the section?
Yeah, I
Okay.
believe so. It'll be for the 2021 year.
Okay.
I have a question. In terms of the reimbursement for providers who might do medical and surgical and then also behavioral health, so like an NP, does the reimbursement change depending on like the office visit that the patient is there for, or is it just a reimbursement rate for the time spent with an NP?
It depends on how they bill it. So if you know the provider themselves decides how they want to code that particular office visit, whether they're coding it as a behavioral health visit or a medical visit.
Well, it also is, there's the E&M part that shouldn't be different, right, between whether it's a behavioral health. But what you're talking about, I think, Melissa, and I don't know if specifically called out, is the add-on psychotherapy code that's available to medical practitioners.
Well, what's interesting about that is, you know, we don't have access to all data, but you know, we have been able to see some trends with certain insurance carriers where in the past they were actually suppressing providers of psychiatric care, medical providers of psychiatric care. They were suppressing their rates along with the rates of just strict behavioral health providers, non-medical behavioral health providers. And then what we've seen over the last couple of years is that some insurance carriers have remedied that and have started to pay psychiatric providers similarly to how they pay straight medical providers, but they have not remedied that discrepancy on just the behavioral provider side of things.
Any other questions or feedback on the median maximum allowable reimbursement rate for a time-based office visit, or any other kind of considerations? I thought this was really helpful to talk through kind of the different billing codes and provider types. Does anyone have a sense for how big of a universe the billing codes and provider types for a time-based office visit would be? I'm sort of just thinking about like the amount of data and how do we make that the most useful for kind of what you're talking about. I think Melissa, and Rachel, about like the aggregate view of the trend in reimbursement. And if you don't have the answer now, that's okay.
I'll try to speak to that because you know, that was a little bit of what our frustration was with the SB 860 data call was you know, kind of just looking at the highest pay of everybody didn't quite capture what we were looking for, because what I think there was a little naivete on our side as behavioral health providers, because I think our variability is probably much smaller than what you see variability on the medical side, because the medical side tends to negotiate their rates to a much greater degree than behavioral health providers. And so that was part of, the definition on page 6 of MMARR that specifically says minus incentive payments. What we're trying to get at there is that a lot of medical providers who are members of large groups, they're able to negotiate for higher conversion factors that increase their overall reimbursement rates, whereas you don't see that as much on the behavioral health side because we tend to be solo practitioners. So this idea of aggregation, on the behavioral side, I think what you see is an aggregation of rates probably on the lower end, and maybe on the medical side, it's perhaps much distributed a little bit more widely. And then one of the questions that we're going to have, and this can be part of the discussion is do we want to add some sort of calculation of data spread to this measure of central tendency? That'll be something that will be up for discussion.
Yeah, as you were talking, I was thinking, right, like when you ask for a median, like the context of that median is helpful to know, right, like the low N and the high N and whatnot. And I don't know if that would be helpful in this reporting, because we do have kind of the catch-all of we can put into rule other data elements that would be helpful. So what are folks' thoughts about kind of, I think you mentioned the SB 860 report had like the highest reimbursement rate that is provided, but kind of capturing the spread.
Yeah, and I discussed that with one of my colleagues who's also on OA MHP, and we talked about how when we use mean as the measure of central tendency, we might look at a standard deviation. And so we asked the question of well, what if we're looking at median? And he looked it up and said that there is a measure of data spread called the median absolute deviation, MAD, the median absolute deviation, which does capture that spread when we're looking at median as a measure of central tendency. So that might be useful for us to look at to get an idea of where the rates aggregate.
To clarify that, then, Melissa, is it, in looking at the data, are we, when we submit this data, is it going to be actual claims incurred reimbursement, or are you working off the negotiated rates high-low? And because sometimes we'll contract providers and they may never use that code, and it may skew the data if we don't know how it's actually, what's actually being used in the market versus what could be used. And so that was just one of those thoughts out there as we go high-low. I'm not sure how much of the data will be skewed from the median, but it is a potential out there and something we can at least say that we talked about.
Yeah, I'd love to have this discussion because we're a little bit blind to how things work on the medical side. On the behavioral health side, we're typically, the majority of us are paid according to a sort of a standard fee schedule that is sort of a base level. And then I'm sure there are some group practices who are able to maybe who have a large market share in a particular area that can negotiate a higher rate. But the majority of us who are solo practitioners tend to be, paid off of this sort of base level standard reimbursement schedule. On the medical end of things, that's a question that we have. Is there that sort of a standard base schedule that, if you take away those incentive payments, the negotiated higher conversion factors, what are we left with? Or on the medical side, is it all negotiated? We have been able to see data from certain carriers who do make that available to all of us, that there does seem to be a base rate for what physicians are also paid. So that's kind of, this is not easy to look at. probably the most accurate thing would be if we literally looked at all submitted claims, but that sounds awfully cumbersome. And then the other piece of this is, you know, DCBS doesn't have access to provider contracts. And so we're trying to help them get information that enables them to do their job, to do the monitoring effectively. And so we would love to have your help as carriers on how we can get at this.
Yeah, I think that the challenge there is, you know, you're probably aware each carrier has their own ways of doing the provider reimbursement, and it's hard to provide data, even any type of narrative that we don't, you know. I mean, we've tried this in the years past, and it's a real challenge. So I agree with you to try to get to an apples to apples between medical and behavioral. Cassie, has the division had any thoughts? I mean, you did the Senate Bill 860 data call, and I mean, did we learn anything there that we can do in doing this data request?
We did do the Senate Bill 860, and I will say that I don't know if Tasha is here, but she would be the best person to kind of respond to that question about what we've learned from Senate Bill 860 and moving forward.
Hi.
I don't know if she's on the line. Okay.
Sorry, I couldn't get on at the beginning, guys. I had a conflict. So I don't have all of the details with me about the Senate Bill 860 stuff because, like I said, I just got off another call. But Gary, can you retell me that question again so I can make sure I got it right?
Well, Tasha, I was trying to talk about Melissa here. We're trying to get to a place where we can compare the reimbursement between medical and the behavioral health. And in doing that, did we learn anything from Senate Bill 860 work that the division can say, hey, here's how we can do it? Like with us, you guys interviewed us afterwards and you really broke it down in the reimbursement area. And so I'm looking at the division because they've seen everybody's data. You know, what commonality can we get to so that when we do this data request, we can get and answer, you know, the information or questions that are out there.
Yeah. So I've been listening, and I hope you guys don't have that echo. I was able to look through that report, and there were a couple of things that sort of came to mind for me as we were looking through the results of all of the insurers. So I think we, first of all, kind of took the wrong amount and aggregated the codes. So what I could do in between now and the next RAC meeting is I can pull the codes that we found that had been aggregated that were problematic and pull those out and separate those out. The other thing that I can do, share is that having the provider types and the CPT code separated out is going to be really important, because what we found with the blending of the rates, and I think I've used this term in speaking with some folks on the phone, is that we can hide a lot of crimes in data, and it's just the way that we ask the question. So I think that if we separate that out and get more specific, the data call and the examination under Senate Bill 860 just aggregated too much, I think. So like I said, I think I can pull that out and share that with this group. And maybe, Melissa, I know you and I have talked a lot about this in the past, and Dr. Mooney as well has sent me some information. So I can use that to maybe construct something to bring back based off of that. Would that be okay, Cassie and Gary?
Sure, no problem. Thank you.
Yeah, that works. All right. Rachel, you have your hand raised.
I do, and I just wanted to do sort of a reminder for folks, because I know you're aware, as we're talking about this, on page 8 of the enrolled bill, it talks about how carriers need to update the methodology and rates for behavioral health providers in an equivalent manner to MedSurg, and that the hope that however we collect this reimbursement data, that it's a tool for making sure that that happens. So I just wanted to sort of give that overarching context as we're having these conversations and as DCBS figures out the best method for doing so, that at the end of the day, that this is a tool to help inform a practice.
Jen.
Thanks. Hi. I just want to kind of recognize that there is a lot of confusion kind of around how to gather this data. And so we just ask that the DFR be very specific and clear with carriers on the expectation, because and Tasha and I had conversations. I don't necessarily appreciate the hide a lot of crimes, because I don't feel like there's any crimes being committed by any of the health plans. However, data can be misleading in certain circumstances. So please be clear on what your expectations are of us. So.
Yes, thank you, Jen. Not all of them are crimes. There are just a lot of things that can be hidden.
Or not crimes, but no one's committing any crimes here.
Right. We just need to make sure it's clear, like you said.
Dan.
Thanks. So just to can respond to Melissa's question, I think it fits here too in terms of methodology. I think that the 860 report did include, it had that maximum, which I agree was not helpful data. But I think the last piece of that report included the standard methodologies, which included what looked like standard rates for medical, standard rates for behavioral health. In my experience in this industry is that what Melissa said is true, that there's a standard for medical, there's a standard for behavioral health, and that there's negotiations on some of those, and probably more negotiation happening on the medical, for the reasons that you said, that you've got large hospital systems that have a lot more negotiating leverage than an individual provider does.
Great. Any other thoughts or feedback on the reimbursement rate for time-based office visits? It was like, I found this discussion really helpful, kind of, and for us to be thinking about as we do construct rules around the reporting requirements. And Jen, definitely want to make sure that everything is clear, and also meets kind of the expectations of this group in terms of what we're looking to try to, the universe we're trying to define, and if those data elements get us that universe or that picture in terms of mental health parity and compliance piece that goes with this reporting. All right, so moving on to a different reimbursement rate. This is the geographic regions for different provider types. Those provider types are listed in the bill. Thoughts, questions, concerns, things that we should be thinking about?
I'm wondering if the intent there is also median maximum allowable, although it's not spelled out in I and J.
Does anyone who was involved with the bill know if that was talked about or discussed for the reimbursement rate? If not, it's a good point of we should clarify what we mean by a reimbursement rate.
I just wanted to say,
sounds like Okay, go for it, Melissa.
I was just going to say I had that same exact thought, right? As you were saying it, so I appreciate you expressing it. But for people who aren't, I wasn't. Well, this one really gets at comparisons that we saw in the two Milliman reports, 2017 and 2019, that were very useful, where they looked just as a way of looking at differences. They compared medical and behavioral to Medicare, percentage of Medicare allowed rates, and tried to use that as a way to look at trends and discrepancies. And if you haven't already seen those reports, they're excellent and definitely show some pretty interesting things. And you can pull specific data state by state from their reports. So you can even look at Oregon's specific data.
Melissa, could you send the link to those reports to myself and Lisa so we can distribute it to everyone so they have that as a reference point?
Yes, I would be happy to do that. And I actually even created a couple of graphics just using the Oregon data, because the Milliman is, of course, a national report, and I was trying to pull out what was going on in Oregon, and I'd be happy to send that as well.
Great, thank you.
I'm also wondering if we have a common understanding of what constitutes a geographic region, or whether that needs to be defined.
That is currently defined under Oregon law. Sorry, this overlaps some of my other areas. So during the next meeting, we have a handy little map that shows that, and I can make sure that Cassie and Lisa have that to distribute to everybody.
Great, thank you.
Hey, Tasha, this is Gary. Is that the rating?
Yep.
Geography? Okay.
Yep.
Then the one follows up on that, Tasha, is we talked about modifying those regions. Are they getting into enough detail? Maybe we can talk about that next time once we see all the regions.
So we did talk about modifying that and put it off for a couple of years. I could also kind of bring back to the group what our decision was on why we didn't modify that, so that if the group wants to take another look at that and kind of understand that, we can also have that information for the next discussion.
Well, from the group, I asked the other RAC members, was there any discussion during this bill of what regions they consider in Oregon? Is there a 4-region Oregon, or is it 7 regions? Any idea what they're thinking there? Or was even the 7 regions that Oregon has now for rates sufficient?
That didn't come up in our discussion. So I think if there's a definition in law and a map to look at, we'll like to review that. Thanks.
Thank you.
So kind of comparing this data reporting element to the one we just talked about for the rate for each behavioral treatment provider type. Is the list in sub I for the geographic region, is that a good list to go off of? I know we talked about grouping it by different provider types. Does it make sense to just make those two consistent between for reporting, or does it make sense to go with kind of a grouping standard for the median maximum allowable reimbursement rate for H? And it's okay if no one has thoughts on this. It was just,
well, Jesse, I think it goes back to,
we've got a list in this one, and then we're talking about grouping in another one. Gary, did you have thoughts?
well, I'm saying it depends on your analysis, because we're saying Senate Bill 860 wasn't, detailed enough. So do the, for the division's analysis, are those groupings that are called out in the bill, if they're sufficient, then yeah, I would say let's be consistent throughout the data. Call and use those up above. But again, I'm not really sure how in-depth an analysis and how many subgroups or groupings you want to make.
Melissa?
I think that carriers can maybe clarify this, but from my understanding, looking at, so I'm looking at the list at the top of page 3 here. My understanding is that there is a natural grouping on the behavioral health end of things where psychiatric providers, which include psychiatrists and psychiatric mental health nurse practitioners, tend to get paid at the same sort of within the same group. Psychologists are a group, and then the master's level clinical social workers, professional counselors, and marriage and family therapists tend to get paid as a group. But if that isn't actually the case, then maybe the carriers can clarify that. So the point being just that if we looked at all of them, separately, there might be some redundancy. That's all.
Dan.
I totally agree. I mean, we can provide it however you want it, but to me, it makes sense to lump the master's level people together because that's how we do it operationally, and I'm guessing other carriers do as well. It may also make sense to look at the psychiatric mental health nurse practitioners because Oregon law, there's a requirement for how we reimburse psychiatric mental health nurse practitioners in independent practice that treats them differently from how they're reimbursed in group practice. It may be useful to report on those things separately so that we're not combining apples and oranges.
That is helpful to know, and I think a good point. Melissa, did you have your hand raised, or is that from previously? Okay.
It was from previously, but I can also say that for this one, looking at the Medicare rates, it does make sense to break them down a little bit differently because my understanding of Medicare is that Medicare groups things their own way, which they tend to put psychologists in with physicians in terms of at that 100% rate. And then I think the master's level behavioral are 75% or 85% of that full rate. So it is necessary to look at it a little different when we're looking at Medicare. I just wanted to clarify that.
Yeah, and I think part of what we can do with some of the reporting is, obviously it sounds like the grouping does make the most sense, but then we can ask a question also that if there are any significant discrepancies between the reimbursement rate within the grouping that we should be aware of, that the insurers can report. If there is, kind of an outlier situation, or I don't know, I think Dan, like you said, right, there's different reimbursement rates depending on the in Oregon law for psychiatric nurse practitioners. I wouldn't have known that, so it's good that you brought that up so that we can be aware of that as we're putting together the rules for this reporting. Any other feedback on the geographic regions and the reimbursement rate reporting? All right, so we'll move on to, I think sub J is we kind of talked about this, about Medicare rates and the providers as well, but is there anything related to the reimbursement rate in the geographic region for a time-based visit and the percentage of the Medicare rate that we should talk about?
I think it may help to define the different types of office time, we've had 45 minutes and 60 minutes. Do we want to separate those out?
This is Tasha. From the data that we received in the past on the Senate Bill 860, I would like to have each of those two pieces between the 45-minute and the 60-minute separated out. I think that would probably be best.
And I think those are the only two. Is there a 15? I don't think there's 15 or 30.
30. Anyway,
there is a 30. Okay, so there's 3 of them. Thank you.
Any other feedback on the time-based office visit for either I or Jay, since they're very similar? Okay, the next subsection is kind of any specific findings or conclusions of the carrier demonstrating compliance with ORS 743A 168 and the federal mental health law. Is there anything that would be helpful in this section? I think, kind of some initial thoughts from our end is we would try to have some specific questions to help kind of guide the narrative that would be written about this section about compliance with those laws.
Yeah, I think if you can identify the key elements that you want part of that, that would be helpful.
Yeah, I think we would, and we would work with our kind of compliance folks of like what they would look for in kind of evaluating that type of compliance and crafting questions or kind of ways that you can respond that are a little bit more specific than kind of a general findings and conclusions. Okay, so moving on to the last catch-all, and I know we're at 11:20. Just want to hear if there's anything specific that we should put on the list for other data and information that we can collect now, and then we'll move into the public comment period. Obviously, robust discussion about the reporting requirements, and I'm sure a robust conversation about the other sections of this bill. So if you are a RAC member, please submit that feedback to us in writing. We're happy to have those conversations and get that feedback so that we can prepare accordingly for our next meeting. Rachel.
Yeah, I just wanted to note that at least on behalf of the coalition that we did not include this language with a specific additional data items in mind, just a recognition that there was probably going to be other things that came up in conversations around implementation, but this was not an attempt to sort of push conversations to this RAC discussion.
Gary.
Question for thought and release those questions on the agenda is, do we need to, or is there a benefit to separating out telemedicine claims versus the other ones? It gets to be a topic once in a while, and I'm not sure in this space if it's necessary.
That's a really good question, Gary. That's a really good point. Probably, and this might save you guys a data call too.
I look for that.
Combined
I think
forces.
we're going to be required to reimburse those telemedicine the same as in person, so there ought not be a discrepancy.
Well, no, but you can see the usage. You might get an idea of usage.
Yeah, that's what I was thinking of as well. The usage, just to see where that was leveling out.
Mm-hmm. Okay.
All right, so I'm going to wrap up our conversation on the bill and specifically the reporting requirement section. Like I said, please submit kind of any feedback that you have for that section, but also the other sections. that if you have any initial feedback or things that we as a division need to be looking at, that would be super helpful for this process. Like I said, we're going to focus on the report section since that is quickly approaching, but I know that we'll have robust conversations about the other sections and what clarity would be needed in rule for that. That being said, we'll move into the public comment portion of the RAC meeting. We will have this every meeting that we conduct. Are there any, Karen, did anyone send their name to you, or is there any interested parties who would like to speak up?
No names.
Okay. Is there anyone on the line that would like to provide any public comment? All right, hearing none, we'll kind of move into talking about next steps. I think that this is a really great discussion, and I've got like a lot of kind of items to think through with our team, with Lisa and Tasha and Spencer, some of our data folks, about how we can best construct this report and thinking through. So what we will do is we will have kind of some draft rules or some draft language for us to look at our next RAC meeting, because I think that will help us, you know, clarify the points that need to be clarified or pick up things that are missed. And so that will probably be the bulk of our conversation next meeting, unless there are things about the other sections that we really need to address sooner than the reporting requirements. So if you can just get that feedback to us so that we can make these RAC meetings efficient and worthwhile, that will be helpful. Anything else from any of the RAC members before we wrap up? All right, well, we can end 5 minutes early. Appreciate all of your time, and especially given to this process, so that we can create some efficient rules so that we address kind of the problem that we're hoping to get at, especially with the data piece. And yeah, look forward to our conversations to come. Karen will be sending out the next meeting, so you will have those on your calendar today. Mm-hmm. I believe the next meeting is September 10th, yes. Just kind of in lieu of Labor Day, and hopefully you will be taking some time off and enjoying a vacation. And we will reconvene then. But please send your feedback to us. We really appreciate it. All righty. Thanks, everyone.
Thank you
very much.
Thank you.
Thanks, Cassie.